So ischemic heart disease, aka coronary artery disease, aka CAD. So these are all just the same names for the same thing, different names for the same thing. So you realize in cardiology we use many different names. This is basically a disease of a mismatch between the oxygen supply and demand of the heart. So supply is supplied by the coronary arteries, which give blood to the heart and thus oxygen. And demand of the heart is governed by how hard it is working, how fast and how hard it is squeezing. So usually we get coronary artery disease due to obstruction of the coronary arteries. And that is usually due to that atherosclerotic plaque that we talked about. So remember this thing blocking up blood flow, so there's less blood going to the heart. And the way this is going to present for most people, first of all, this is a spectrum of diseases which we're going to talk about. There's going to be 4 we're going to talk about. And there's going to be a lot of overlap of symptoms. And what most of them are going to have is they're going to have chest pain. It's going to feel like an elephant is sitting on their chest. It's a crushing chest pain. There's going to be other symptoms. So let's get into it. First one is stable angina. And this one we're going to classify as a stable coronary artery disease. Okay. I'm going to see why we're going to do that in a second. But basically, a stable angina is when we have an atherosclerotic plaque, as you can see here, blocking up over 70% of the coronary artery with diminished blood flow and oxygen supply. So even when you have, let's say, 60 or 50% blockage, that's not enough blockage. You have plenty of supply. There's plenty of room in that artery normally to give blood to the heart. But when you block over 70%, that's where you're going to start feeling that insufficiency of oxygen. What you're going to feel, again, we said that the symptom here is crushing chest pain. And then the key is that it's going to be triggered by exertion and it's going to be relieved with rest or nitroglycerin. That's the classic triad of stable angina. It's crushing chest pain, that's 1. Number 2 is triggered by exertion. And number 3 is relieved with rest or nitroglycerin. And the reason this is because normally for stable angina, these dudes are, when they're just chilling, their heart's not working too hard. So even that 70% blockage isn't enough to make too little blood supply. But when they start exerting themselves, when they start riding, let's say their heart's beating faster, it's beating harder, and it's needing more oxygen, and that's when that 70% is going to kick in. So let's say normally you're sitting here, your demand is low when you're sitting, okay, and supply is high. But when you kick it up a notch, that demand's going to kick way up while the supply stays the same, because your 70% is blocked, and your demand is going to outstrip your supply, and you're going to be feeling symptoms. When you rest, you're going to go back to this state. Your symptoms are going to go away. So treatment is lower yield. I'm going to talk about it anyway, just to be complete. You're going to give them beta blockers, you give them nitrates. This is both going to work to decrease the work of the heart. So it's going to decrease the demand, and so this demand goes back down again, and so symptoms go away. The other thing you're going to do is you're going to give them antiplatelets, so aspirin or clopidogrel. The reason you do this is to prevent further development, worsening of this stable angina. And we're going to talk about why. You're going to prevent thrombosis of that plaque, which can cause much worse things. So what we're talking about here, much worse things include unstable angina. So this is due to thrombosis of that atherosclerotic plaque. So there's all these thrombotic factors inside that plaque, okay? And it's covered by this nice fat cap here that's preventing the thrombotic factors from coming into contact with that blood. But if that plaque for some reason breaks down, then we're going to get this. These factors are going to leak out into the blood, and they're going to cause thrombosis. So you're going to get thrombosis. And in unstable angina, this is going to be an incomplete occlusion. So there's still some blood coming through, but it's not very much at all now. And so because there's some blood coming through, this is called a reversible injury to the myocytes. There is no necrosis occurring, okay? This is pretty important. No necrosis occurring. The features here, the clinical features you're going to experience basically worsening of the stable angina symptoms. So it's either increased intensity or increased frequency, or it's going to be chest pain at rest. And this is the most commonly tested one. They're going to have chest pain at rest now, and you're going to know it's probably unstable angina. Now in EKG, what you're going to see is you may have ST depression or T-wave inversions, and the other key thing is there is no cardiac biomarker elevations. So brief intro on those. Cardiac biomarkers are molecules specifically found in cardiac cells, and they're released when the cardiac cells die. So if you see those, that means there's some cardiac cell necrosis. But we just said here that there's no necrosis, so obviously then there's going to be no cardiac biomarker elevation. Treatment, again, lower yield, but I want to include it, is Monabash. Monabash is a nice mnemonic for everything you need to do for these patients. It's outlined on the bottom here. I'm not going to read it for you. You can read it for yourself. And I've explained why you do what you do. And there's also, you can either do a conservative or invasive treatment strategy. Conservative means you wait for the angina to reoccur. You do a stress test to show that your heart's in bad shape. The invasive strategy is you can do an early cardiac catheterization. That means you stick a catheter, which is basically a tube, up your femoral artery, all the way. You trace that artery all the way back to the heart, and you go into the coronary arteries and you relieve this obstruction, this thrombosis. All right, next is the non-ST elevated MI, non-ST elevated myocardial infarction, also known as NSTEMI in short. So this is the same idea as the unstable angina. You get rupture of that plaque, you get occlusion, you get thrombosis, the blood thrombosis, and you get complete occlusion, and that leads to ischemia. So there's complete occlusion, so there's not enough blood reaching the cardiac wall. So remember, the coronary artery is on the outside. So there's not enough blood. What's going to die first? What's going to die first is the part of the cardiac wall that's farthest away from the coronary arteries. So this part. This is a 1/3 of the subendocardium. It's going to die first. And when that 1/3 dies, it's called NSTEMI, okay? And the symptoms here are going to be, again, it's chest pain, but you're going to see additional symptoms. You're going to see nausea, vomiting, pain in the left jaw, and shortness of breath. Commit that to memory because you're going to ask about that, because that's key. You do not want to miss someone with the cardiac, with the MI. So what will happen to the cardiac biomarkers? Well, we just said they appear when there's necrosis, and there is necrosis now, because we talked about the first 1/3 of the layer is necrosed. So you're going to see elevated cardiac biomarkers, and that's going to be creatine kinase, and it's going to be troponin. The other thing you're going to see is ST depression on EKG, okay? It's going to be ST depression because you still have 2/3 of that wall still working, so it's not going to be elevated yet. The treatment here is going to be the same as unstable angina. You treat it the same as unstable angina. So final one is ST elevated MI or STEMI. This occurs the same thing as a NSTEMI, except for what happens now is there's a full thickness necrosis and infarction. Okay, so symptoms, same thing. Chest pain. What were the symptoms? Chest pain, nausea, vomiting, pain in the left arm and jaw, shortness of breath. No, you don't have to have all these symptoms. You can just have some of these. And what's going to happen to the cardiac biomarkers? Those are going to go up. And then, finally, this is an ST elevation in the EKG. Because, like I said, the whole wall is going to die. So it's not working, so you get ST elevation. Treatment here, Monabash again, as always. And you want to do a percutaneous coronary intervention, PCI, as soon as possible. That's, again, you're going to get into the coronary arteries and relieve that obstruction. If you can't do that, you're going to give them fibrinolytics. This is a medication that you use that can break up that thrombosis and relieve blood flow. So you give fibrinolytic, and I'll look up here, and that thrombosis goes away. Ideally, hopefully. So I just said that this one right here, stable angina, is stable coronary artery disease. These three right here are termed acute coronary syndrome, aka ACS. Okay, and note it's acute. These are acute changes. These are very sudden changes where you have that stable plaque, and suddenly that fibrous cap breaks down, and you get acute thrombosis, leading to acute blockage of that coronary artery, leading to ischemia and death of the cardiac cells. Alright, so this is a very high yield slide. Please note everything I've talked about here, except for the treatment, a little bit lower yield, but it's still very useful.